Hello, Peter. Sorry for the delay.
No worries. All good.
I had some problem for connecting, but now it's okay. And I had clinics and I finished later than expected.
All good.
So the slides, you make the slide on?
Yep.
Okay.
So welcome everybody. Welcome everybody. My name is Peter Nash from the Griffith University in beautiful downtown Brisbane, Australia. And we're very lucky today to have a very excellent group of speakers. We're going to talk a little bit about the highlights of, where's this thing going? Should be able to change slides. These are our fantastic speakers, Professor Xavier Mariette, Lorenzo Dagna, and Sofia Ramiro. And we're going to be talking about the highlights from there's the disclosures if you need to see them, and the highlights of the EULAR 2023 meeting that was just in Milan. And we're going to break that into novel therapies for rheumatoid, the updates with the PSA guidelines and new PSA therapies, and also AXPAR, and we'll throw in for good measure a little bit of lupus at the end. So these are our objectives: novel therapies RA, the latest treatment targets in PSA, emerging therapies AXPAR, some novel data in lupus, and a very exciting couple of things in lupus as well for completeness. And then we'll, and that's the way things will work, just for the agenda and the topics and the speakers as we've discussed. And then we'll move on and have your questions. So please ask your questions in the chat function, and we'll try to get to all of them towards the end of the session. We've got lots and lots to get through. The first speaker is Professor Dagna. He's the head of the Unit of Immunology, Rheumatology, Allergy, and Rare Diseases at the IRCCS San Raffaele Scientific Institute in Milano. He's a fellow of the American College of Physicians, an honorary fellow of the European Federation of Internal Medicine, and a member of the Italian Society for Internal Medicine and the Italian Society of Rheumatology. He serves on section editor for Immunology Rheumatology for the European Journal of Internal Medicine. So over to you, Lorenzo. Let's hear about what's the latest in PSA from EULAR 2023.
Thank you very much, Peter, for your kind introduction, and to CSF for organizing this nice symposium. I will be going through some abstract that we selected for your attention, and we'll be discussing probably one of the main point that was presented at the EULAR last week in Milan, namely the new recommendation for treating psoriatic arthritis. So, the first poster, the first presentation that we selected was actually about extramusculoskeletal manifestation in patients with psoriatic arthritis treated ankylosing spondylitis or non-radiographic axial spondyloarthritis treated with upadacitinib. We know that extramusculoskeletal manifestation of SPA are frequent, but there are limited data about the effect of JAK inhibitors and upadacitinib in particular on the treatment of EMMs in patients with SPA. And indeed, this study actually aimed at analyzing the potentiality of developing an extramusculoskeletal manifestation of PSA, AS on radiographic XPA in patients treated with upadacitinib or placebo in the context of the SELECT clinical trial. So actually, they studied the manifestation of those, the specific appearance of this manifestation. Most of the patients, as you can see here, actually did not have a prior history of an extramusculoskeletal manifestation at baseline. And what it came out is in patients, for example, with psoriatic arthritis, the development of uveitis and IBD were in general low as expected, regardless of prior treatment history. In patients with ankylosing spondylitis, as again expected, we had a more elevated frequency of developing uveitis, and that was more present in patients receiving placebo than in patients receiving upadacitinib 15. And occurrence of IBD and PSO were in general low, regardless of previous treatment history. Again, in patients with non-radiographic AxSpA, development of uveitis was very low, regardless of any history. And again, the total rate was significantly higher in patients treated with placebo versus patients treated with upadacitinib. In general, in both groups, both treated with placebo and with the drug, the occurrence of IBD and psoriasis were low or absent. So in general, the study can conclude that the development of extramusculoskeletal manifestation in patient with spondyloarthritis was in generally low, and in some group was lower in patient treated with upadacitinib. Another study presented the data about the efficacy and safety of bimekizumab in patients that had active psoriatic arthritis and a prior not adequate response to TNF inhibitor. And indeed, we know that bimekizumab selectively inhibit interleukin-17F and A, and it has been shown to have very good efficacy and tolerability in up to 16 weeks. And also the efficacy has been demonstrated up to 552 weeks in patients in the treatment with psoriatic arthritis. The scope of this study was, as I told you, to study specifically the patients that were TNF non-responders or inadequate responders and follow up them up to 52 weeks. And the study found out that, again, most of the patients, 97% of the patients reached week 16, whereas nearly 90% of the patients completed the treatment up to week 52. And efficacy was good of the drug and was sustained up to week 16 and week 52. And actually, roughly 52% of patients treated with bimekizumab and 46 patients treated first with placebo and then rescued with bimekizumab achieved an ACR 50 at week 52. And patient actually that had significant psoriasis, and in particular, they have psoriasis that was covering more than 3% of body surface area. 66% of them, of those treated with bimekizumab, and 60% of those treated with first with placebo and rescued with bimekizumab achieved a PASI 100, so very good results on the skin also. And patients were also able to reach the MDA at week 52, and 47% of patients treated with the antibody and 33% treated first with placebo and then rescued with bimekizumab were able to achieve the MDA at week 52. Significant proportion of patients has at least one adverse event as followed up with week 52. But in general, bimekizumab, according to the study, proved effective in treating patients with PSA, even in the population on TNF and non-adequate responders from week 16 and week 52, and the safety profile was perfectly consistent with what reported previously. This study was another interesting study that was presented at a poster during EULAR 2023, and actually was trying to compare the effectiveness of biologic and targeted synthetic DMARD in patients with psoriatic arthritis according to their comorbidity status. We know that comorbidity are becoming extremely relevant in the choice of treatment, and as you are perfectly aware, the recent EMA recommendation take in significant consideration comorbidities at the beginning of the treatment. And so, scope of the study was to analyze if there were any differences in the 1-year retention and the 6-month effectiveness in PSA patients that have or not have comorbidities at treatment start. And in particular, patients receiving interleukin-6 inhibitor were compared to TNF inhibitors, and patients receiving a JAK inhibitor were compared also against TNF inhibitor that was considered the reference for the treatment. And in general, what it came out that patients starting a TNF inhibitor were more often men, and more often were also using a concomitant conventional systemic DMARD. And in general, patients treated with TNF inhibitors were less likely to have comorbidities, and versus those treated with an interleukin-17 inhibitors or with JAK inhibitor that have a greater degree of comorbidities. This is probably due because in general, Interleukin-17 inhibition and JAK inhibitor in this study were second and third line treatment. So most patients in general were receiving a TNF inhibitor. And indeed, as I was telling you, interleukin-6 inhibitor and JAK inhibitor were more frequently used in patients having failed 3 or more biological or targeted synthetic DMARDs. In general, it has been seen that patients were less likely to discontinue an interleukin-17 inhibitor than a TNF inhibitor, independent of the fact that they have or not comorbidities. In general, the patients that were receiving JAK inhibitor, on the other side, had greater risk of discontinuing the treatment in the population without comorbidities, but in patients with comorbidities, no differences were found between a JAK inhibitors treated patient and a TNF inhibitor patient. And also was interesting that patients with at least one comorbidities, there were no significant difference between the treatment of the capacities on the effectiveness of the drug, of those drug used for achieving LDA. And among patients without comorbidities, a greater proportion of patients treated with TNF inhibitor were able to achieve low disease activity versus interleukin-17 and JAK inhibitors. And if you specifically study adalimumab among all the TNF inhibitors, there were no differences as if you take in consideration that's just a single drug or the entire class of drug. So the study could conclude that the retention and effectiveness of JAK inhibitor and TNF are similar in patients with at least one pre-existing comorbidity, but as I told you, JAK inhibitor seems to be less effective than TNF inhibitors in patients without comorbidities. Another study that was presented at EULAR as a poster was actually analyzing the capacity of the BASDAI and ASDAS in evaluating action involvement in patients with PSA, specifically those treated in the population of patients treated with guselkumab. We know that BASDAI is used to analyze and to assess the activity of axial disease in patients with PSA. However, just one single question is specific to axial symptoms. On the other hand, we know that ASDAS excluded assessment of enthesitis and give definitely less weight to peripheral activity. And somehow, in general, ASDAS is considered to be more objective than BASDAI. And in this analysis, actually, the scope was compared to indexes in the specific population to draw a conclusion about those two indexes. And what it came out is that in patients with axial PSA, BASDAI was correlated poorly with the swollen joint count, with the tender joint count, and with the Leeds enthesitis score and the physician global. Wherever there was a moderate correlation with fatigue from the patient and a very strong correlation with the PGA and patient pain. And the similar results were also observed in parallel for ASDAS. In patients with PSA, but without axial PSA, correlation of BASDAI and ASDAI remain weak with the SJ, swollen joint count, the tender joint count, and the Leeds enthesitis index. And whereas the correlation with the patient global and the patient pain remains strong. Among patients with or without enthesitis, there was a significant but not clinically relevant association of the Leeds enthesitis index and the swollen joint count in the indexes and the other outcome. Clearly, the presence of an axial disease was associated with a greater BASDAI and ASDAS score, either at baseline and longitudinally, and there was no significant differences in the incremental effect of those indices in analyzing the activity of the actual activity of the disease, both in the standard version and the modified version. So the study could conclude that those two indexes actually can perform very similarly in patients with axial PSA, and in general, were able to have a similar ability to discern changes in axial disease activity in patients with PSA. Another very interesting study that was presented as an oral presentation at EULAR was this one that actually discussed about the determinant of radiographic progression in early PSA patients. We know that radiographic structural damage is still prevalent in PSA patients, and the investigators found out if there were some specific characteristics that were able at baseline to suggest a risk for progressing during treatment. And indeed, what it came out is that patient had a radiographic progression in 2 years, as somehow as expecting a significantly higher median score in the modified total sharp score and the joint space narrowing score at diagnosis. And the progressions group also has a significantly higher swollen joint count, but that's actually was not significantly higher. It was in general numerically higher. Also, it was seen that patient has a higher CRP level at baseline in those that progressed. But again, the difference was not statistically significant if you use this as a continuous measure. But if you take a cutoff level of 1 milligram per deciliter of CRP, patients that progressed were more likely to have a value of CRP that was over this threshold. And in general, the DAPSA, the ESR, and the presence of dactylitis or enthesitis as baseline did not differ between the group. And indeed, the study can conclude that after 2 years of follow-up, older age, swollen joints, erosive disease, a joint space narrowing score, and baseline CRP is, if intended as greater than 1 mg per deciliter, may be predictors of radiographic progression. And as I told you, my last topic of my presentation will be the EULAR recommendation, the updated recommendation of management of PSA that was presented by Professor Logosé at the last day of the EULAR. And something changed, something was made new, and something was maintained from the previous recommendation. And to go through that, those were the 7 overarching principles. Actually, there were 6 overarching principles that were slightly rephrased. The 7th overarching principle that was added to the discussion was that the choice of treatment should take account of safety consideration regarding individual mode of action to optimize the benefit-risk profile. And that was clearly a consequence of the discussion that came out specifically for JAK inhibitors and in general about the evaluation of the benefit-risk profile of treatment for all patients with rheumatic condition. And if we move to the recommendation, there were some variation in the recommendation. Those are the first 5 recommendation. The first one was the same. Actually, it has been somehow rediscussed and significantly rediscussed the usage of corticosteroids in treating patients with psoriatic arthritis. And as you can see, recommendation number 2, actually, there is no room in the recommendation for using systemic corticosteroids. It's left the possibility of using injection of glucocorticoid, intra-articular injection, but not the use of systemic corticosteroids. Also, again, it has been a little bit rephrased, the recommendation number 3 that now reads that patients with polyarthritis or those with monooligoarthritis and poor prognostic factor, a rapidly initiation of a conventional systemic DMARDs and specifically methotrexate that is preferred in patients that have a clinically relevant skin involvement should be added as early as possible. Number 4 remained unchanged, and number 5 again it was rephrased, taking into consideration the new guidelines about the new suggestion about JAK inhibitors. So again, at least when BDMARD has been failed or a BDMARD is not appropriate, JAK could be considered taking safety consideration into account. And the second part of the recommendation were somehow modified and changed again. Number 6 was not changed. Patient with mild disease and inadequate response, or at least one conventional systemic DMARD, or in whom actually a BDMARD or JAK inhibitor could be not considered appropriate. We can consider a PDA4 inhibitor. Patient with enthesitis and an insufficient response to anti-inflammatory drug or local glucocorticoid injection, again, we should be moving directly to treat them with BDMARD. And this is something that has been modified, and the following one also that was considered were pointing out, as I will be showing you in the following slide, actually strongly to the different pattern of presentation and the different patterns of non-musculoskeletal manifestation related to PSA. And they actually should be guiding our choice of the specific drug to be used for those patients. Namely, again, it has been said that patient that has a clinically relevant axial disease and an insufficient response to NSAID, we should be taking in consideration an interleukin-17 inhibitor, a TNF inhibitor, a double inhibitor, ANF of interleukin-17, or a JAK inhibitor, also taking in mind the caution that I told you before. And again, if you have a specific non-musculoskeletal manifestation, then you should be choosing a specific group of drugs depending on the non-skeletal manifestation. As is shown here, if you have a relevant skin involvement, for example, it's preferred to use an interleukin-17A or ANF inhibitor, a 23 inhibitor, or an interleukin-12 and 23 inhibitor. If you have uveitis, the ideal choice should be going through a TNF inhibitor and specifically to a monoclonal antibody. And if you have a coexistent inflammatory bowel disease, again, you should be going to a TNF inhibitor, a monoclonal antibody, or a 1233 or a 23 or a JAK inhibitor, taking in mind, again, the caution. And the last consideration, again, patients should be switched to another BDMARD or JAK inhibitor if they develop an intolerance or inadequate response to this drug. And again, it has been added that if you have a patient which is in sustained remission, a tapering of a DMARD should be considered. And I think we can move over to the next presentation. And I thank you for the moment for the attention. As suggested by Professor Nash, we will be happy to take your question at the end of the entire discussion.
So super, that's fantastic. Thanks for sticking to time as well as a beautiful presentation. We're very fortunate now to have Professor Xavier Mariette with us. He is the head of the rheumatology department at the Bicentre Hospital Paris Sud in University and the co-author of many, many publications. He heads the French Ratio Observatory. He serves as president of the Club Rheumatism and Inflammation for many years. And that should be right. And he's initiated the French AIR and the ORA registries of patients. So we're very appreciative of your time. Thank you, Xavier, to tell us a little bit about the novel therapies in the management of rheumatoid coming out of EULAR Milan. Thanks, Xavier. Have to unmute yourself.
Yeah, sorry about that. Thank you so much, Peter. I'm very happy to present you the crème de la crème of rheumatoid arthritis presentation in EULAR. As you know, rheumatoid arthritis is always, in all rheumatology congresses, one of the diseases in which there is the most important progresses. And still now, at the time we have a lot of treatments in RA, we still had very, very nice presentation. So I selected 6 abstract, only 6, but very different, and to give you a flavor of what was said about RA in Milan. So the first abstract is about the efficacy of vaccination against zoster in patients treated with upadacitinib. You do know that with JAK inhibitors, like with any DMARD, there is some concern about the efficacy of vaccination. You also know that the drug which may impair the most vaccination is methotrexate, is paradoxally, and also you also know that rituximab may also have an effect on the vaccination efficacy, whereas anti-cytokine antibodies are relatively safe and neutral in this domain. So it was interesting to hear this communication from Kevin Winthrop, so the communication concerned patients treated with upadacitinib plus methotrexate, and that's important. And you can see it is an open study, and you can see that most of the patients received methotrexate, and the humoral response against zoster vaccination was pretty good, because 64% of the patients responded to zoster vaccination at week 4 and 88% at week 16, if we look at the humoral response. If we look at a cellular response, the response was also pretty good, as you can see here, 62 and 66% of the patients. No serious adverse event. So the conclusion is that the majority of the patients with RA receiving UPADA 15 milligram QD with background methotrexate achieve a satisfactory response to this recombinant zoster vaccine at week 16. The second, my second selection is a new drug. It's not so common to have new drugs in RA. And this new drug is really interesting because it is a PD-1 agonist. You all know PD-1 antagonist, anti-PD-1 antibody, which are a major drug for the treatment of cancer now. And it has been a revolution in the treatment of cancer with immune checkpoint inhibitor. So anti-PD-1 antibodies are going to awake the T cells. And in our diseases, we want to slow down the activation of the T cells. And exactly what does this drug? It is a converse of anti-PD-1. It's an agonist of PD-1, which is a negative immune checkpoint. And you can see that it is a proof of concept it works. It is a classical phase 2 study with 2 doses of peresolimab versus placebo. And you can see that at 12 weeks, so the endpoint is very, very short, at 12 weeks, sorry, you can clearly see a difference between the 2 doses of peresolimab versus placebo, whatever the outcome, the DAS28-CRP or the CDAI. So I think it is interesting because this drug, it should be logical that it could go in phase 3. It is a new mechanism. Of course, we have to be very cautious about the possible risk of cancer, but we use abatacept, which is the converse of ipilimumab, the anti-CTLA-4, and until now, there is no demonstration of increased risk of cancer with abatacept. My third selection concerns JAK inhibitor safety. Of course, it's a big debate after oral surveillance. And now the question is, do the different registries all over the world, having recruited patients on JAK inhibitors, do they reproduce the excess of MACE and cancer regarding TNF inhibitors found in oral surveillance, in the specific population of oral surveillance? So it is a jackpot. The jackpot is a mix of different European, American, Japanese, Australian registries with patients with JAK inhibitors. And the primary endpoint was the MACE in this study. And you see there is 35,000 patients, so it's a lot, 182 MACE, and the crude incidence of MACE was not increased when they compared JAK inhibitors, you can see here, TNF inhibitors, and other mechanisms of action. So it was the same. Nevertheless, we have to be cautious because the duration of treatment with each of these JAK inhibitors remains relatively low. And you do know that we have to wait for a longer time to address the risk of cancer, especially the risk of cancer, but also the risk of MACE with this type of drug. My first selection was an epidemiology presentation, the first day of EULAR, about interstitial lung disease in patients with RA or with psoriatic arthritis starting biological DMARD. And so it was a very large epidemiological study all over UK. And the objective was to compare these incidents versus the general population and the role of methotrexate co-medication. So there are 2 messages. The first one is there is an increase of ILD in RA. You see that the hazard ratio was 10 compared to the general population, but also an increase of ILD in psoriatic arthritis with an hazard ratio of 5. And that is a surprise for me because it was not expected. We can have a discussion on that later. But it is the first time that there was this suggestion of an increase of lung disease in psoriatic arthritis. And last but not least, co-medication with methotrexate didn't give any increased risk of ILD in our RA patients. So overall, there is no increased risk of lung disease in our patients treated with methotrexate. Last, I will come back again on the safety of JAK inhibitors. You do know that the big question after oral surveillance is it a TOFA effect or is it a class effect concerning all JAK inhibitors? So we would really love to have the same study during 3 to 5 years comparing TNF inhibitors and Upada, Filgo, and Barry. But unfortunately, we probably will not have. So we have to look at the risk of the different adverse event in the development program made by the company with these molecules. Of course, regarding the risk of cancer, we cannot compare to placebo because patients of placebo are treated only for maximum 6 months for ethical reasons. But we can compare the 2 doses of the drug which were given during the development program. And it is what was done in this study on filgotinib that was presented as a poster. And the message are, if you compare 100 and 200, there is no difference in MACE, whatever the age of the patients, before 65 or after 65. Of course, you have more events after 65. If you look at the comparison of malignancies, overall, there is no difference between 100 and 200. But if you focus on patients more than 65, there is a numerical increase of non-melanoma skin cancer and a slight numerical increase of overall malignancies in patients treated with 200 versus 100. So we need more follow-up to have a conclusion on that. And the last abstract may be the most exciting one. It was presented as a late-breaking session, and it is a phase 2 study from China comparing a new JAK inhibitors to tofacitinib. And this new JAK inhibitor is very original because it's going to inhibit JAK1 and TYK2. TYK2 is one of the JAK, one of the 4 JAKs, which is involved in the pathway of type 1 interferon and in the pathway of IL-12, IL-23. So these two pathways are inhibiting when you inhibit TYK2. So it's very complementary to JAK1. And look at the results. It is a randomized control study, 4 groups, 3 doses of the new inhibitor, TLL, and 1 group with tofa. ACR 50 was obtained in 42% of patients with tofa. It is exactly what is expected. But look at with the 3 doses, ACR 15, 48, 65, and 72, 72% ACR 50. We never saw that with this drug of with ACR 50 with this drug. So of course, we have to be cautious. We have to wait for confirmation. It is only one study from one country, China, but clearly new JAK inhibitors could be even more effective than the current JAK inhibitors we have today. Thank you very much for your attention.
So that's super. Thank you so much, Xavier. We're very fortunate to have Dr. Sophia Ramiro. She's a consultant rheumatologist and senior researcher at the Zuiderland Medical Center and Leiden University Medical Center. Many publications, a member of the EULAR Scientific Committee, member of the Executive Committee of ASAS, and the advisory board of the EULAR School of Rheumatology. Please put all your questions in the chat. And we thank Dr. Ramiro for her time. She's going to tell us about what were the emerging therapies for the treatment of axSpA shown at EULAR 2023 in Milan. Thank you so much, Sophia.
Thank you very much, Peter, for this very kind introduction. It is my pleasure to be here to share with you highlights from our Congress on Axial SPA. So if we move to the next slide. Yes. So I start to share with you a first presentation that was held on the first day on an ASAS consensus definition for early Axial SPA. It's not a definition intended for daily clinical practice, but I think it's good that we're all aware of it. And I think we will hopefully expect to see studies using it, trials, research studies, cohort studies using this definition. Up to now, we did not have any consensus in the field of Axial SPA as to what we consider early Axial SPA, as we do have in RA, and actually the definition has changed throughout time and it became more stringent throughout time. So we started with an ASAS project and we conducted a systematic literature review followed by a Delphi and consensus exercise until we have reached a definition. As you can see on this slide, we agree that patients with the diagnosis of Axial SPA with a duration of axial symptoms of up to 2 years are considered as early Axial SPA. And axial symptoms should include spinal or buttock pain or morning stiffness and should be considered by a rheumatologist as related to Axial SPA. So I think it's a relatively straightforward definition, especially if we look at the footnote is an explanation of it, but it's mainly patients with a duration of axial symptoms up to 2 years, meaning that we do not want to start counting, considering early Axial SPA if a patient has an extra musculoskeletal manifestation, for example, 20 years before having the onset of chronic back pain. So we focus on the starting point of the actual symptoms, and we expect that this definition will be used in the near future in research studies. And we have a lot of new data from several molecules that we have for the treatment of axial SPA. And I start here with bimekizumab. We have already seen bimekizumab data for PSA. So we know that bimekizumab inhibits IL-17A and F with the dual inhibition. It has shown previously efficacy for both non-radiographic and radiographic axial SPA. So two separate trials that have been conducted. And here we present, our data were presented from both trials in terms of the long-term efficacy at 52 weeks. And we can see that efficacy was sustained up to week 52 in both non-radiographic and in radiographic axial SPA. And efficacy at week 52 was similar in those that had always been exposed to bimekizumab and also to patients that had been exposed in the first 16 weeks to placebo and then switched to bimekizumab. On the right-hand side, you see here a figure of the other states over time, where we can see that on the left-hand side, we see that the data on non-radiographic axial SPA, first on baseline, then on week 16, and then on week 52. And we see that the green parts of the graphs are increasing. That means patients who are in low disease activity. And on the right-hand side, the same for radiographic axial SPA. In terms of safety, 75% of the patients in both trials, non-radiographic and radiographic axial SPA, had at least one treatment emergent adverse event, most of them being nasopharyngitis, upper respiratory tract infection. Serious adverse events had a low incidence. There were no MACEs, no tuberculosis or serious COVID-19 or death. Fungal infections are usually a point of concern for IL-17 inhibition. And in this study, we have seen that most of the fungal infections that have occurred were candida infections, mild to moderate, and there were no serious or systemic fungal infections up to week 52. And we move to the next abstract, a poster, but we stay in the bimekizumab trials. So the B-Mobile 1 and 2 are non-radiographic and radiographic axial SPA. And this abstract deals with effect on MRI inflammation. On the right-hand side, we have graphs showing first the effect on the spark on the SI joints. So MRI inflammation on the SI joints, first non-radiographic axial SPA, then radiographic axial SPA. And on the right-hand side, we have the inflammation in the spine as measured with the Berlin score, first for non-radiographic and then for radiographic axial SPA. In both, we see that there is a clear discrimination at 16 weeks, so the timing of the primary endpoints between placebo and bimekizumab, with bimekizumab suppressing inflammation, but much more after week 16, both treatment arms, both groups received bimekizumab, and then we see a decrease in inflammation to similar levels also in the group that initially received placebo and then received bimekizumab. On the left-hand side, we have a table reflecting how many patients achieved remission according to definitions on the MRI, on the SIJ, and on the spine for both the non-radiographic and radiographic axial SPA. And we see for outcomes, or two outcomes in the two groups, a significantly higher achievement of remission with bimekizumab compared to placebo. So bottom line, in MRI inflammatory lesions are effectively suppressed at both the SI joints and the spine. Now we switch to another mode of action, JAK inhibitors. We already have heard data on upadacitinib today, and this is data on non-radiographic axial SPA. This is a particular study and important because we have data placebo-controlled up to 52 weeks. The primary endpoint was at week 14, and the data had been previously presented and shown efficacy for upadacitinib demonstrated and a clear discrimination compared to placebo. But then we continued having placebo up to week 52. This was a requirement from the FDA at the moment that the study was developed, that there were, especially by the FDA, there were concerns whether non-radiographic axial SPA would be a disease that would persist if it would not be treated, whether worse outcomes would persist. And here we have again beautifully shown that indeed non-radiographic axial SPA is a real disease, and if kept untreated, so for placebo, only with placebo for a long time, worse outcomes are achieved compared if we treat in this case with upadacitinib. efficacy was maintained up to week 52. And in terms of adverse events, they were similar. There were no new safety signals that as compared to what had been shown before. Now we switch to another abstract. This is an oral presentation of a head-to-head trial. So it's a pivotal trial in Axial SPA because unfortunately we hardly have any head-to-head studies, and certainly well-performed head-to-head studies. So this was a very expected study in which secukinumab and adalimumab were compared. And the focus and the primary endpoint and most of the secondary endpoints of the study were on structural damage. That means that the study aimed at investigating whether secukinumab could inhibit more structural damage progression, which means syndesmophyte formation, than adalimumab. It's also the first study that has had a structural outcome as a primary endpoint. Patients were compared at 2 years, so the proportion of progression between the two arms. And actually, as you can see on the cumulative probability plot on the right-hand side, there's actually no difference in the progression between the groups. And the primary endpoint was the proportion of patients without radiographic progression at week 104, so 2 years. And this was also similar between the groups. So the question is the glass half full or half empty? I think the glass is half full because although this is a negative trial, we see that radiographic progression was low, although this was a trial population that was enriched with patients that had a high likelihood of progression of structural damage, patients with a positive CRP or patients with syndesmophytes, and still we see a low progression and without significant differences between the treatment arms. So it means that both arms are suppressing well the disease activity in order to control the progression of structural damage. And another analysis of this same trial, so it was presented as a poster in which patients were analyzed according to subgroups, a subgroup of patients that had at baseline both positive CRP and presence of syndesmophytes, and then patients who only had positive syndesmophytes but no positive CRP, and patients who only had CRP but no syndesmophytes. And as expected, a higher progression was seen in a group with both risk factors, so positive CRP and positive syndesmophytes, followed by the group with positive syndesmophytes. And we know that syndesmophyte presence is the highest predictor for future development of syndesmophytes. So not surprising that the same happened here. And then the lowest in the group that was only CRP positive. And in each of these subgroups, the same conclusion was drawn that in the complete trial, the overall population, which means that there was no difference between the treatment arms of secukinumab and adalimumab in what concerns inhibition of structural damage progression. And then I moved to the last two abstracts that were presented on Axial SPA. This first one was presented in the abstract plenary session of the Congress. It's data from the SPACE cohort. It's a cohort in Leiden in which patients with unknown origin chronic back pain are followed up for 2 years, and diagnosis workup is made at baseline and then repeated at 1 and 2 years. And the primary outcome of this study was to assess the diagnosis at 2 years. And what do we see here? Out of 555 patients with chronic back pain, in 32% diagnosis of definite axial SPA, so a diagnosis in which the rheumatologist was confident about it with a level of confidence of at least 7. This was present in 32% of the patients, and following patients up to 2 years, 30% of the patients had the diagnosis of definite axial SPA. And we see that there were some changes, but not many in patients that moved from definite axial SPA to no axial SPA, 6%. On the other hand, 9% of the patients moved from no to definite axial SPA. And this allows to conclude that in general, in most of the cases, the diagnosis could be already established at baseline. And there are some SPA features that are associated with this diagnosis already at baseline, not surprising. Imaging detected sacroiliitis appears to be the best discriminator in terms of the presence of the diagnosis at 2 years. And I think it's also important to mention that in 14% of the cases, there remains uncertainty after 2 years. And I think this is in line with the daily clinical practice. And the last abstract, also from the same cohorts and continuing on the same analysis, here there was a more detailed zoom into which diagnosis category patients obtained at baseline. And you can see on the right-hand side in the figure, patients are here stratified into a definite axial SPA, on the right-hand side, definite no axial SPA, and in between some uncertainty level. And then looking at what happened in the transition to the 2 years. And in between, we have a bar with a change that you can see here, where we see that of the 175 patients with definite axial SPA, 133 remained in the same class. But then we can see that this total of patients, 3 + 3 + 7, transitioned from definite axial SPA to no axial SPA. 29 patients transitioned to most likely axial SPA, but this also has to do with some losses to follow up so that we could not have a definite diagnosis at 2 years. And we can also see that in total, 16 + 12 + 5 transitioned from the remaining classes to definite axial SPA at 2 years. So that means 33 patients changed to definite axial SPA over 2 years. And on average, those patients already had at baseline through to 3 to 4 axial SPA features, and on average 1 to 2 was newly presented during the 2-year follow-up. And among those, we see mainly MRI, sacroiliitis, newly presented, or a new good response to NSAIDs. But in general, a repeated assessment of the SPA features gave only a modest yield, as the diagnosis could already be established in most of the patients already at baseline, which I think is reassuring for us all seeing patients in daily clinical practice. And this brings me to the end, so I give the word back to Peter. Thank you very much for your attention.
Well, that was superb. Thank you so much. And thank you to all the speakers who beautifully kept to time. That was going to be the end, but I thought we've got one of the biggest areas of unmet need, which is lupus. And there was a number of very important presentations regarding lupus at this meeting. And I thought that I might squeeze a couple of presentations in if you can see that screen. So, with analumab, which is an anti-BAFF, showed some nice positive efficacy in a small phase 2. That'll move on to phase 3. But this was a very interesting one because the treatment of lupus with JAKs has been a little bit up and down. Deucravacitinib, the TYK2 inhibitor, showed a nice SRI4 response with a low placebo, and they're moving ahead with the phase 3 study that we're doing in a multinational cohort. So we're hoping that the phase 2 success transmits into a phase 3 success in lupus. But this particular study, again, it was a small study. Again, it came from China, and they looked at baricitinib. Sorry, it came from Egypt, not China. One country, small study, 60 patients, but very interesting results because they compared head-to-head intravenous cyclophosphamide monthly for 6 months with oral baricitinib. And we know that the baricitinib study failed and didn't meet its primary endpoint in their lupus study, despite having a very good SRI4 result, 57%, no different to deucravacitinib. The big difference was the placebo response. Deucravacitinib response in the 30s, therefore a positive result. Barry, placebo in the 45 range, negative result, drug no longer proceeded with. So these guys looked at 4 milligrams, not 2, but 4 against cyclophosphamide and showed very nice results with an unusual outcome measure. Their primary was change more than 50% reduction in proteinuria at 6 months. And they showed very nice results with superiority against intravenous cyclophosphamide. So a 24-week study, small numbers from one country. We're kind of getting a theme here: Chinese, Egyptian, small studies, fantastic results, need to be confirmed in bigger studies multinationally across the board. They did look at other measures, FLEED-I2K, reduction in complements, reduction in double-stranded DNA, and all of those things were positive in favor of baricitinib. So Lilly has not taken baricitinib forward in lupus. This is a study that may raise questions about that choice. Now, more JAKs in lupus. This was a study that they showed a couple of arms from a much larger study. They did two studies in one, if you like. They looked at upadacitinib, both 15 and 30 milligrams, to see if that would be effective, but they added a BTK inhibitor. Now, the BTK inhibitor, osimertinib, was combined with either 15 UPA or 30 UPA, or the BTK inhibitor by itself, or the UPA 30 by itself, or placebo in a phase 2 study. So they had a number of arms, and here they reported the BTK plus 30 against placebo because adding the BTK gave no benefit over UPA by itself. Now, you might say this is just a short study of 6 months, and if you're going to use a BTK inhibitor to turn off B-cell production of autoantibodies, which live for 3 to 4 months once you've got them on board, you really need to look in the second 6 months, not the first 6 months, if you're going to see real positive events. But either way, the combination added no benefit effective. So you needed 30 milligrams of UPA to have a positive effect and significant results. And you needed that to beat placebo significantly. They didn't see much in the way of VTE, but this study excluded those patients with phospholipid antibodies, etc. They had less flares on the UPA 30. They have reduction in double-stranded DNA. They even showed some improvement in interferon gene signatures, which may be the way JAKs might work in lupus. Not 12/23 inhibition, but interferon reduction. So another watch this space. I don't know if AbbVie will go forward with UPA in lupus, but they had a positive result from this study. The BTK inhibitor was not helpful. Now, there's a couple of studies with telitacicept. We were involved with the atacicept studies rather, which showed nice efficacy, but because of infective problems, that drug was abandoned and not moved forward with. This is telitacicept. It's another Chinese study, and it had fantastic results, almost too good to believe. This is a dual inhibitor of BLyS, which other name is BAFF, and APRIL as well. This is the 52-week follow-up of what they showed at ACR that went for 6 months. And again, they showed very significant benefits over placebo with the telitacicept. They're having SRI-4s of 67%. We haven't seen that with any other drug, and placebo's nice and low at 33%. So they looked at, this was NRI results, so they should have been quite strict in their statistical measures. They had an increased time to flare. They had improvements in complement. They had reduction in gamma globulins, and no new safety signals were demonstrated. So again, that's their phase 2 study results out to a year. We're looking at telitacicept, a combined BAFF APRIL inhibitor. We would like to see the big multinational phase 3, which we're currently just about to start. And they looked at Sjogren's as well. Now, Sjogren's is very difficult to study because the outcome measures are particularly, in my opinion, difficult and not very well at distinguishing active drug from placebo. They used ESDI, they used MFI-20, but they did show a favorable safety profile, and they were able to show some efficacy in Sjogren's disease, a disease that we really struggle with and need better outcome measures. I think the CRESS is the best outcome measure because not only does it do disease activity, does it do PROs, it does a tear gland function, it does salivary gland function, it does some biomarkers, biological biomarkers, and some inflammatory markers as well. So for me, the CRESS is the way to move forward with Sjogren's studies. Now, the most exciting of all, I've gone from being anti to highly pro in the use of CAR-T therapy for refractory lupus. Now, CAR-T therapy, this is the follow-up of the 7 patients that Georg Schett from Erlangen presented at ACR. They're now out to a year plus. One of the patients out to 22 months. And you have to understand that these patients were all young, in their 20s mainly. They had very resistant, aggressive disease. So they had a mean of 4 organs involved. They had a mean of failed 7 treatments, including biologics, Ritux, cyclophosphamide, etc. One of them had failed 15 treatments for lupus. I didn't even know 15 treatments existed for lupus. They normalized their baseline SLEDAI of 16 down to 0. They hit LL-DAS, DORIS remission very quickly. They lost their autoantibodies. They only had 1 mild grade 1 cytokine release that needed tocilizumab for fever. They had no neurotoxicity in this particular study, the so-called ICANS, and they're all in drug-free remission out over a year. No steroid, no immunosuppression at all. And just to remind you, the way this is done, you take the patient's T cells, you, by leukapheresis, you activate them. So you have to have them off drug, except maybe low-dose steroid for adrenal cover, for 3 weeks before they get the CAR T cells. Then you transduce those T cells that you've expanded in the test tube using a lentivirus, so it makes the CAR that recognizes CD19. Then you expand that population and infuse them back into the patient. But you have to use the conditioning, which is always the question. Do they need conditioning with cyclophosphamide and fludarabine? And the answer is yes, because you have to empty the niches, according to Georg Schett, so that the CAR T cells can expand in all those niches, so you can get complete B cell depletion. The CAR Ts expand very dramatically, lasts a few days and disappears to very low levels. You can keep some in the fridge and give it to the person later if they do relapse. In this cohort, none relapsed. And you then infuse the CAR T. The B cells come back at a mean of 122 days, but they're all naive B cells that do not have memory to a previous triggering antigen. So they come back with a very almost baby immune system, and Georg argues that the autoimmunity has been reset. So a very interesting cohort, one group. So a Chinese group presented a second cohort of another dozen or so patients, also very resistant patients, also all in complete drug-free remission after an extended period of time. One relapse that was treated with a second CAR T, and they're also now in remission. They used a slightly different CAR. They added a B-cell migration antigen that kills the plasma cell. Georg Schett gets to the plasma blast from the pro-B cell, but leaves the plasma cell alone so they don't get infection. And the Chinese ones eliminated the plasma cell. They got hypogammaglobulinemia. They did get some infection. You had to give these patients gamma globulin, but that's almost like 2 separate groups now looking at this same question. The other things presented at this meeting were the use of CAR T therapy for Jo1 positive myositis. They presented 2 patients. One had a CK of 9,000, had failed everything. The other had a CK of 3,000 and failed everything. Both are now in remission with normal CK, normal muscles. And there was a letter from Georg's group to the Lancet, I think, or maybe Annals, where they've tried this in scleroderma in 4 patients and had some very nice results. So if you take people who are desperately ill with lupus, who are young, who are bad prognosis, who have failed everything, and you give them a treatment that's very expensive, in the EU, it's about 235,000 euros to make the CAR T, but you give them 1 to 2 years of drug-free remission. That sounds like not a bad option if you're the person in that position living on steroids and immunosuppression. So I can't wait for this to be extended into other groups, into other countries, into bigger cohorts, so we can actually show the safety and long-term efficacy. And even if they relapse, they can be retreated. It strikes me that this is a very important advance in the treatment of connective tissue diseases. So I think we've had a fantastic group of presentations, PSA, RA, AxSpA, even a bit of lupus thrown in. We're very happy to take any questions through the chat function. And I'll start with a question to Professor Dagner that's in the chat. Can he reassure us, or his opinion on whether IL-17A and F inhibition has any advantage over IL-17A inhibition alone? So adding A and F, does it add anything over A alone?
This is a very difficult question, and this type of question were quite clearly addressed during the presentation of the guideline. So at this very stage, there are data that may be showing some kind of differences between the response, slight differences between the response of the different biologics in the same population, but you are actually comparing different study populations. So it's quite difficult to understand if those numerical differences that you see are due to some selection questions, some facts connected to selection in the different study groups. And indeed, the position of the group presenting the recommendation was that there were no data, scientifically sound data, supporting a prioritization of one biologic drug to another. So as long as we do not have enough numbers, maybe also real-world data that can be of some benefit, but clearly, if we do not have a head-to-head study comparing the two, even slightly different mechanism of action, it's quite difficult to drive a conclusion that is scientifically sound and not based on a feeling or something like that. So far, we have no data on preferring one single biologic over another in the treatment of psoriatic arthritis.
Thank you very much. And a question for Xavier about vaccines, particularly the Zostavax. There's a concern that it might flare the rheumatoid arthritis. What do you think of Zostavax flaring RA, Xavier?
Yeah, it's a good question. In the study I have presented, it's not Zostavax, it is recombinant vaccine.
Oh, sorry, the Shingrix it is, yes.
The Shingrix, yeah.
The Shingrix flare RA.
Okay. Actually, it was one of the objectives of this study just to check that there was no increased risk of flare, and actually it was the case in this study. Now, and after the COVID time, we are more and more reassured regarding globally the safety of vaccine in general in RA. You do know that, for example, for the COVID vaccine, we conducted in Europe a big study in 5,000 patients with different rheumatic diseases who have been vaccinated with the COVID vaccine. And we found a flare of the disease in 5% of patients only, and a severe flare in 0.6% of patients. I think it is the same for Shingrix, and I think the message is very reassuring, at least at the epidemiological level. There is no risk, very small risk of severe flare with this vaccine in our patients.
Super. There's a question for Sophia. When should we use JAKs in AxSpA, Sophia, with all the controversy about the JAKs? When would you see them used?
Very good question. As I think everyone knows, in terms of recommendations, we recommended all the drug classes with efficacy demonstrated at the same level. So when we consider that a patient should be treated with a biologic or a targeted synthetic DMARD, any of the drug classes, TNF inhibitor, IL-17 inhibitor, or JAK inhibitor can be used. However, we decided as a task force to emphasize that current practice is to start with a TNF inhibitor or an IL-17 inhibitor, and that is also my personal opinion. I think that as a first line, it makes more sense in principle to use drugs for which we have more accumulated experience, more safety data, more use in patients with multimorbidity, and we also have on the other side only short-term data with JAK inhibitors in Axial SPA, and we have the safety signals from oral surveillance. So short answer is first line TNF inhibitor and IL-17 inhibitor. As a second line, I think any of them can be certainly considered, including JAK inhibitors.
Excellent. And another question about 17. With SURPASS, they showed they're almost identical. If you believe less opportunistic infection, less TB, less bacterial infection, is it time to think about 17s before TNFs, unless the biosimilars and the costs drive the regulators to a biosimilar first?
Yeah, I think that in terms of efficacy and safety, they are both at the same level. Eventually, safety even a little bit better for IL-17, as you were mentioning. But then indeed, costs drives very often the decisions. And I think that's where people have to see also locally how they are reimbursed. And if with the same amount of money, we can treat several patients, then I think the choice often is made in that sense.
Exactly. Ernest Choi was telling me that in the UK, subcutaneous methotrexate is more expensive than
biologic, than a TNF.
That's
correct.
Amazing. That's incredible.
Yes.
All right. Well, we've come to the end of our time, and I thank all our fantastic speakers, Professor Dagna Ramiro and Xavier Mariette, for beautiful presentations, the highlights of EULAR 2023 in beautiful Milan. And I thank the audience for their time and attention, and we hope you found this a worthwhile presentation. Thank you to all the speakers. Thank you, everyone.